So I'm doing ethics from Toronto Notes. You also have to do ethics from CMPA as well. CMPA has everything more elaborative, and you can always Google your questions from CMPA. It will help you to figure out what's the answer of the question. Starting from this one, physician licensure and certification. So you need to know which certifying body gives you what. Okay, this is a very important question. It can be asked in the exam as well because they do like to ask you questions from here, especially from this table. Everyone, I think, do get one question from here. So MCC gives you certified physician with LMCC. LMCC acquires after MCC QE1 and MCQE1 2. Then RCPS PSC, they certifies residents who completed an accredited residency. So after completing CARMS and after passing that exam, there is a CPSC exam. After that, the RCPSC give you a licensure that you can independent practice leave. Voluntary membership of the RCPS is designated for FRCPC or FRSCSC, like for medicine and surgery. Then CFPC certifies residents who completed an residential family medicine residency and passed the certifying exam in the family medicine. So this is basically that license or the certificate that you get. After that, you can practice independently. Then comes the licensing body. 13 provincial medical like regulatory authorities, all postgraduate residents, all the certifying physicians must hold an educational and practicing license from the licensing body. Like if you are from Pakistan, you have a licensing from PMDC. If you are from India, there is a different. If you are from Bangladesh, it's different. So, everyone has some sort of license from back home after doing a postgraduate residency. Then comes the CPSO. So please keep it in your head. It can be asked in the scenario which can be given to you, and after MCCQE1, who gave you that test, and this can be asked like MCC gives you what kind of license. So that's what you need to remember. Then CPSO is basically the membership to the, so there is one with the royal physician. I don't think so it's written here, so you have to go into Google and see what does the royal physician gives you. Okay, like what kind of licensing they give you. Then the membership to the, so CPSO gives you the licensing authority functions, including the non-transferable licensure of the physician. It works with the ethics, legal competency standards. Then against the physician, they do investigation, then do misconduct and incompetence, and then the licensure investigation renewal, how they're going to disclose that. And physician must disclose if they have a condition like HIV, drug addiction, or other illness, so they can be tested according to that. Then again, they have written down whatever the same thing here. The self-regulation is controlled by whatever the things, and then who gives you which kind of certificate, and what is the certificate that you get after giving what kind of exam. Then again, the key professional association is CMA, CMPA, RDO, CPHO, CFMP, and then PTMAs. So CMA is basically the provide the leadership to the physician and advocates to the high quality care in the Canada, physician and population concerns at the national level. So this works on the national level. Membership is regulatory for all the people. So especially for physicians, you do have to get it. Then PTMA. PTM is basically the regulatory fee and then benefit schedule with the provincial. So that was for the national level. The provincial level is basically PTMA. This one is presents the economic and provincial professional interest of the physician, and membership is regulatory. Then CMPA. In this one, if a physician is liable for any kind of malpractice and negligence by a patient, in that case, CMPA helps the physician to get over with that one. Physician run organization protects the integrity of the physician. So if physician get any kind of liability, malpractice, in that case, CMPA helps them. Provide risk factors and the educational programs, and the membership is voluntarily. Then comes this one. RDOC and PHO. In this one, upholds an economic and professional interest of the residents. Facilitates the discussion between PHO's regulatory policy and then advocacy items. Then CFMS is basically medical students are presented in the regulation, the bodies, and then controlling their whatever the medical schools are going through. Then again, we are going to start with the ethics. You can read ethics more if you have more time than from CMPA. If you have less time, then do this one and then do the MCQs from CMPA. That's more than enough for the ethics point of view. Again, when you are doing or dealing with any kind of ethic question, keep it in your head that you have to make sure that whatever the answer is in the benefit of the patient, and you have to always listen to the patient. And if there is any kind of contraindication or there is any kind of conflict, in that cases you have to bring them together and talk about it, where there is counseling, talking. Those kind of answers are always the correct one. And when there is questions like, where there is conflict and, mother is having problem, sister, father is having problem, in that case is bringing them together is the answer. If patient or person is more than 18, in that cases you have to listen to the patient, whatever their best interest is. And then if someone is not capable of making the decision, in that cases you have to listen to SDMs, substitute decision maker. So please keep it in your head whenever you are doing ethics. It's just simply you have to listen to the patient, whatever they are saying, wrong, right, whatever it is, because it's their health and you have to go along with that. Then again, if they want to kill themselves in the case of emergencies, you have to listen what is best for their saving the life. Ethics involve the thinking about what the best course of actions may be the specific case. So principles and values are help us to determine the morally permissible and then impermissible in the specific situation. So rights, duties, and obligations for the individuals and the groups. Then the self-regulated professionals, ethics, and then professional practices is the shared coded of the conduct and the provincial body, so everything works together. The physician-patient relationship should be based on the trust, confidentiality, duty, and responsibility towards the patient. The fiduciary duty is the legal duty to act in another party's interest, so you have to make sure you listen to the patient. Profit from the fiduciary relationship must be strict, accounted for with an improper profit resulting in the section about the physician potential. So you have to always make sure whatever you are doing, it should be the best interest of the patient. Like if in some cases there is like patient is not in the best interest, but if the patient was in the best senses or able to make the decision, he would listen to that one. So in that cases, you have to go with whatever the decision patient would have made if he was in the conscious state. Then comes the autonomy and competency and capacity. Autonomy is the right that the patients have the decision to make. Then comes the competence. If they are understand, so sometimes in the competence they try to give a question like a 8-year-old boy, he just diagnosed with Burkitt lymphoma, and he was given an idea about chemotherapy, but he denies, he does not want to take the chemotherapy. Although he fully understands what Burkitt lymphoma is. Now they told you that even an 8-year-old boy, he understands, he has competency, ability to make a specific decision for oneself, determined legally by the court. So this is basically their competence. They do understand what the condition is. They do understand what the side effects of not treating it. They do understand the consequences of chemotherapy. Like they do understand everything because they mentioned that this boy knows what Burkitt lymphoma is. So in that cases, if he's saying, I don't want to get the treatment, in that cases, you have to fully respect his choice, although he's 8 years old boy. So did it make it any sense to you? Because he is 8 years old boy, but he is able to understand what is Burkitt lymphoma and everything. And they do specifically mention the scenario. It means they want you to listen to the boy. Okay. Then comes the capacity, the ability to make a decision for oneself or determined by the clinicians proposing the specific treatment. Okay, so if they understand, they are able to, they have that ability to make the decision. Then comes the autonomy. Autonomy is like, thinking about whatever they wanted to do, if it's right, wrong, whatever they want. Recognizes the patient's right to make the decision. But in the same time, you have to check for the competence, like they do understand that one or not. Okay, autonomy is not synonymous with the capacity. Sometimes they are not capable of making the decision, but they are saying it, and in their written note they have signed that thing, like they do understand everything. Then in that cases you have to go along with whatever the patient wishes is. Then comes the benefit, although it's wrong, they don't have the capacity. But again, if a person is depressed, if a person is having anxiety and things like that that can affect their psychological point of view, in that cases you have to think of what it's best for the patient or looking for substitute decision maker. Then comes the beneficence. Beneficence is basically obligation to provide benefit to the patient. So you have to make sure whatever you're treatment, whatever it is. Even for the autonomies, basically, you have to tell them about the beneficence of the treatment and the beliefs and everything. So beneficence is like benefit to the patient, whatever it is, may be limited by the principle of autonomy. Sometimes they don't want to get the benefit, so you have to listen to whatever they want. Paramount in situation where the consent is not possible. Then the more non-maleficence, if there is no benefit, there should be no harm. Okay. So then obligation to provide avoid causing harm. So it says first do not harm, then comes the benefit. So you have to make sure whatever your decision is, whatever the patient is choosing, it does not harm it. So let's suppose if they are talking about, okay, in this case, we will be doing antibiotics for you for any kind of like things. So antibiotics is the treatment, but the patient is like, no, I want to get the surgery. But the thing is, surgery can cause a harm to that patient. So in that cases, you have to tell them the consequences of surgery, and if he does not want to go for antibiotics, but then you should have asked him to avoid for the surgery as well. So do not harm, and then comes the beneficence. A limiting principle of the beneficence principle. Then comes the justice. Justice is the fair distribution of the benefits and the harm. So it is basically depends on equality and equity. So basically, when it comes to justice, justice is like, for everyone, even he's from Bangladesh, he's from Pakistan, he's from India, he's from Sri Lanka, he's from wherever it is, they all will have the equal rights, like they have the health card and they will get enjoy health free. Okay, so this is basically justice, fair distribution to everyone. Concept of fairness is basically this patient receiving what they deserve, their fair share. Like, if they are like, with the insurance, or not with the insurance, let's say if they blood work with one person with the health card, if he's enjoying that free blood work, the other person should also be enjoying the free blood work, then he shouldn't be paying for that. So this is basically equality. Then are they treated the same as equally situated patient? And then how does one set of treatment decision impacts the others? So now when we are talking about the equity and equality, equity is basically getting everyone getting everything similar. Okay, so if I'm giving vitamin D to this person, I will be giving vitamin D to the other person. I will be giving the vitamin, like there's 5% in the room, I'll give all of them vitamin D. Now, when we are doing the vitamin D blood work, I will be doing calcium test. I will be checking his things that he is more prone to get osteoporosis, or he has more chances of getting vitamin D low. In that cases, I will be giving only the blood work to that person. Now this comes the equality, like if that person needs that treatment or not. Okay, so in 5% in the room, maybe 1% is needed for the vitamin D. But otherwise, we can start vitamin D for everyone. Vitamin D can be given to everyone because they are deficient or insufficient for that anyway. So in that cases, you can give them vitamin D, but who needs to do the blood work? Because here we are using the resources from the government. So you have to be very conscious about where are and which person needs the vitamin D testing. Okay, so that's what the difference between equality and equity. So equality provides the distribution of resources to all people, irresponsible to anything. So equality is like all of that. Then comes the equity, distributing resources in a way that consider different needs, like depending on which one needs it. So equal, like everyone is getting equal. So that is equality. Equity, like, which one needs the first. Then CMA, Code of the Ethics and Profession. CMA is basically the Code of Ethics and Profession. They are the providers standard of the ethic practice to guide the clinical physicians. So because, if a physician got liable for any negligence and everything, they do help them to protect them. Fundamental consequences of the medical profession and then responsibilities. So they do work for the physicians, but they make sure that the physician do follow all those professionals' liabilities. Negligence is not being done. The Code of the Ethics and Professionalism is prepared by the physician for the physicians and applies to the physician, residents, and the medical students. So they have to follow them. Inform ethical decision making where existing guidelines are insufficient or the values and principles come into tension. It should be non-exhausting, so you have to watch out for the burnout and stuff like that. You have to give them, time out if they need time out. So you have to provide them all of those ones. And then they should follow the human rights. They should follow the proper ethic decision in those cases. CMA policies addresses the specific health ethical issues. Topics not mentioned by the code is basically abortion, transplantation, medical assistance in dying. Then the CMA Code of Ethics and Professionalism is a quasi-legal standard for physicians. If the law sets a minimal moral standard for the patient, the code seeks to augment these standards. So if a code says or law says, it shouldn't be done, then in that case is the code of the ethics CMA works to make it implement. Okay. CMA is basically, implementing the laws. Like if someone does, like if a law is basically stating that, physician is not, if a physician is not comfortable in doing abortion, he can refer that patient. Now, this is basically a something given by the law that, if you're not comfortable, you can always refer the patient, but you are not able to deny it that you don't need to do abortion or whatever. So in that cases, it's basically the CMA's duty to implement it on the physician. Okay, so our physician is not capable of telling them to not do the abortion. All they can do is refer it. Okay, so CMA Code of Ethics and Professionalism, virtues exemplifies by the ethical physician, like compassion, honesty, humility, integrity, prudence is there in the fundamental. What are those ones? The well-being of the patient, respect for the person, justice, integrity, competence, then professional self-care, peer support, and then inquiry and reflection. When we are talking about the physician and the patient, what are the responsibilities, their relationship, their decision making? When we are talking about the patient, physicians, and then practice of the medicine, in that case, it is basically physician privacy and then duty of confidentiality and managing and minimizing the conflict of interest. So if there is a conflict of interest, bring them together, talk about it and figure it out. And you have to be non-judgmental. And then if there is a confidentiality, so make sure wherever possible, if there is any chance, slight chance of breaking the confidentiality, try to avoid it. Then the physician and self-awareness of wellness service, like he's not burnout, he's not depressed, he's not a substance abuser and all that. Promote health among themselves, then seek support for the professional and then personal problems, then the safe training and the working environment. Then physician and the colleagues, in that case, is treating colleagues with respect and dignity. So you have to make sure that, if there is a senior or anyone, he should be respectable to the juniors, and juniors have to be respectable to the seniors. Take responsibility for the action towards the colleagues. And yeah, there is one scenario here that comes to my mind. Like if a person, like you are a team of 5 people, in team of 5 people, one person make a mistake, and and a patient came back, like who did it? Like they did a perform a surgery, and then something happened in there over there, like it got contaminated or something, and some in one person in the team that made the mistake. So in that cases, if a physician comes, sorry, the patient come back and asking who is the one, I will talk to that guy. So you as a physician, you will not reveal that was the person, and you will go and talk to that guy. So in that cases, all you have to do is that we all work together in a team. If there is a mistake happen, we all will be liable for that, and we are sorry about that. We'll try to improve it and see what best we can do for that. So if you see this, in that cases, you are not breaking confidentiality, you are making that respect and dignity for the colleagues, and at the same time, you are helping that colleague and helping the patient what to do for that one. So please, if there's any scenario that comes here where they're asking about if you reveal the confidentiality about the colleagues, that's also a wrong answer. Don't break any confidentiality among the colleagues as well. Then the physician and the society commitment to high quality service, then recognition of the social determinants of the health, and then the equitable access to the resources. So everyone should enjoy all of that. So you, in that cases, how you offer flu shot for all patients every yearly. So this is basically giving them the equal rights to all of them. Then comes the confidentiality. Okay, now in the exam, they do like to check confidentiality a lot, because which countries we belong to, I don't think so we practice confidentiality as much as it's practiced here. And I think I discussed a lot of scenarios with you. So a better understanding of confidentiality is, if you are a working person, like I'm just giving you an example. If you are a working person and because in confidentiality, when someone is stranger, you can always do the confidentiality. But when confidentiality is mainly challenged is when you have someone and that person is asking about something. Okay. So in that case is, no, you are not supposed to break the confidentiality. If someone is your brother or your colleague or something like that, you saw in the hospital, in that cases he did not see you but you saw him, in that cases you will not approach him. In the second case scenario, you saw him, he saw you. In that case, you will approach him, but not ask him. Okay, unless he opens up to you. Third case scenario, you talk to him. You saw him, he saw you. He comes and talk to you. In that cases, you will talk to him, but you will not break the confidentiality or did not ask him why he's here or what is going on. In the third case scenario, you talk to him, you saw him, he saw you, he talked to you, he asked for help. Okay, asking for help. In that cases, you do help him, but at the same time will not ask why do you want to go there or why do you want to see that doctor. Okay, so that's how you keep help. Like, you will do everything, but you will not break the confidentiality or you will not ask the things. I hope this helps you to check with that scenario. Then when they're saying the legal and the ethical surrounding the patient start from the fundamental assumptions that all the information given by the patient is confidential unless asked by law. Okay, that's even how we do the statement when someone patient enters in the clinic. We say, okay, whatever we are going to talk about is going to stay confidential unless asked by the law. In that cases, I do have to reveal it. So whatever you talk to me, it will be staying confidential. It helps the next person to understand that they can open up about anything. Both confidential and privilege then determine whether the exceptions to this exist. Now you have to think of where the exceptions are. First thing is, obviously, I told you about the law. Privacy is the right of the patients, while confidentiality is the duty of the physician, where they must respect the bearing, the consent, and then requirement of the law. The patients have the right of the expectations by their personal professional with the receive proper protection from unauthorized access. If the confidentiality is inappropriately breached, that physician can be sectioned by hospital, court, or by the regulatory body. Then, based on the ethical principles of autonomy, patients have the right to control their own health information. Then confidentiality may be ethically and legally breached. What could be that case is the child abuse, geriatric abuse. In that case, where you have to report STIs. In that cases, you do have to report it. In that cases, we will do the break of the confidentiality. Like if someone got diagnosed with chlamydia and gonorrhea, you have to report it to the public health. If someone needs to do pap test, you have to break it to the public health. If someone has to do the mammogram, you have to tell to the public health. Okay, so these are something where they need to be like screen and testing and all that. So this is something where you will break the confidentiality. Many jurisdictions that make mandatory not the reporting of the serious communicable diseases like HIV, that also reporting of those who harbor the agent of the communicable disease. So physicians failing to abide those regulations must be subject to professional or the civil actions. Legal duty to maintain the patient confidentiality is imposed by the legal legislation, and those ones are controlling that one. So if you see in the site, this legal aspect of the confidentiality advice should always be sought from the provincial licensing authority. So please keep it in your head that it is controlled by the provisional, not the national, not federal, no one, provisional level. Okay, or the legal council when in doubt. Then CMA Code of Ethics and Professionalism, obviously their duty is to make sure they implement whatever it is according to the law, so that no physician will break that thing. So in that case, what they're taking is patients by keeping their identified patient information, collecting, using, and disclosing much health information to benefit the patients, and sharing information only to the benefit of the patient within the circle of care. So if this is going to help them, then that in that case is like, how I'm going to inform the pap tests to help them. Okay. So if this is going to help them, then we are going to break the confidentiality. This is a very important question where they ask about screening point of view. Are you going to break the confidentiality? Yes, in screening point of view, because it's going to help them. So in that cases, definitely we have to do that. Then the statutory reporting obligations. Legislation has defined the specific circumstances where the public interest overrides the patient's right to confidentiality. What are that one? So they have given all of those ones. Child abuse, fitness to drive, communicable diseases. What are those ones? STIs and all of those ones. Then the improper conduct of the physician and then health professional, like, if they have sexually harassed a patient, or one physician has sexually harassed someone or some colleague, or something like that. So in that cases, you have to report. Or if you are doubtful, you can talk to your supervisor. So wherever you are doubtful, in that cases, first talk to that person? The first answer is wherever you feel like there is a doubt and they're asking what will you do next. In that case, is first talking to that person. Second will be talking to the supervisor. Third will be talking to the hospital management. Fourth will be telling to the conduct or whatever it is. Okay, so that's how you're going to do it. And if they ask that you have seen someone or you are sure about that, in that case, you can directly go to the conduct one like CMA or all those. Okay, so I hope this makes sense. Like, how are you going to deal with this one by one? Then the vital statistics must be reported. Reporting varies by the provinces, must be reported. Uh, sorry, required to be reported within 30 days of the office of the registrar. Like how many people have died in one of the provinces or in that further area. Reporting to coroners, if a coroner had find out something, in that cases you have to let them know, like it's an HIV patient, so they can sterilize their instruments and everything. Physicians who fail to protect their situations are subject to prosecution and penalty. Then again, they're talking about the Ontario's how they do the duty of harm, so you can read that one. It's just for Ontario. Duty to protect and warn. In that case, is the physician has the duty to protect and the public from a known dangerous patient. So if someone says, "Oh, I'm going to kill that person," and you think that he has an intent and he has access to the weapon, in that cases you have to inform to the police, and in that cases you have to inform to that patient as well. Again, a gunshot wound, you have to report to the police. Again, the rabies is also something you have to report to the public health. The physician has the duty to protect the public from a known dangerous patient. This may involve taking appropriate clinical actions. Which one are those ones? Involuntary determinants of the violent patients are for the clinical assessment, informing the police, and then warning the potential victim. Canadian courts have not expressly imposed a mandatory duty to report. However, the CMA Code of Ethics usually says that you have to report it. Report of the breaching confidentiality should not, those ones, there is like, in which cases you are going to do that. There is an imminent risk, identifiable person, and then seriously body harm or death can happen. Then disclosure for the legal proceeding, in which cases, like I told about law, which one are those ones? Like a court order, warrant, or sub apnea. Now a patient can, like not patient, a police comes and ask about the patient, identity and everything. In that cases, you will not break the confidentiality. You will not tell them. If they bring a written order and they told in the scenario that they have a warrant, they have a written order, in that cases you will break the confidentiality. But if they say verbally, it's no. Okay, even though it's police, they are wearing uniform, everything, but they don't have any warrant or court order or nothing, in that cases you will not break the confidentiality. So please keep it in your head what words and what lines they have been telling you, because this is something they can ask you, that police is there and asking you. So we do think, okay, it's law, so we do it. No, it does not work like that. Then the privacy of the health information is protected by the Professional Code of Ethics, provisional and federal legislation. Again, I was talking about they are controlled by the provisional ethics and federal, but it's mainly controlled by the provisional one. Then the federal government created PPD in 2000, and in that case, they're talking about the physician practice and checking for that one. CMA Code of Ethics and Professional protect the health information of your patients, provide information reasonable circumstances, collection, use, and disclosure of their health information. Be aware of your patient's right, what they can ask, use, disclosure. If someone is asking for some disclosure, like, filling up disability form and asking them to attach a specialist report, now they are asking for it. In that case, it definitely you will disclose it. Duties of physician with the regard to the privacy of the health information. So this is basically FIA. For your understanding, this is called FIA. Like you have to, like their health information, they have, like, it's a controlling body that controls that how much it should be given to that one. So usually patients sign that FIA form and then we break the confidentiality. Duties of physician with regard to the privacy of the health information. Now comes a log box. So log boxes, like the circle of care is like a 5, 10, 6 people are working together on one patient, like multidisciplinary team. There is one main person, like a family physician person or the main in charge physician of that guy who is taking care of that physician. Sorry, not physician, the patient. Okay. In that cases, what do we do is that that in charge person or that physician has all the information. Now, if a patient asks you to not disclose his HIV history to the other circle of care, it's your liability, so it's your duty to not share it with that one. Okay, but we assumed that when circle of care works together, a patient express consent needed not to be obtained to share the information because they all are working together. So patient knows that five people are working together, everyone has my medical record. So in that cases, we do share it. But if a patient particularly told you don't tell my HIV test results or my this thing to anyone, in that cases, even the circle of care will not get it. I hope this understands you. Here they particularly told you. And then there is a lockbox. Lockbox is where the patient tell you this part information should be kept in my thing. So that's what we are talking about in the side box. If you can see, the lockbox is basically applies to the situation the patient has expressed restricted that this information should not be shared. So this is I was talking about FIFA. So Personal Health Information Protection Act. In that case, it is basically the provides denotes that the patients may not prevent the physician from disclosing the health information required by the law. So FIA is basically in which we do share the information even if it's in lockbox to the law, but not to the circle of care. Okay. So for the law, it's everything is applicable. Then again, reasons of the breach of confidentiality is child abuse, fitness to drive, coroner report, communicable disease, and duty of inform. Coroner report is basically, when a coroner find out that the person is murdered, not died. Okay, like he did not die a natural death, he was murdered. In that case, obviously, you have to tell them it is murdered or whatever is going on. Then come back again in this part here, the second point. The physician has the professional obligation to facilitate the timely transmission of the patient's medical record to the third party. So, like if a patient is changing clinic, so question can come from a changing clinic. So in that cases, if he's not happy with anyone or he wanted to change the clinician and asking for medical records, in that cases they can pay. Okay, a physician can charge how much he wants. Okay, and he can pay and he can transfer his medical records to the next person. Okay. Such as for the insurance claims and then disability form, even that one we have to share it. Failure to do so has inserted in the section of the regulatory bodies. While patient has the rights to assess their medical records, so if some patient comes over, okay, I want my medical records, can I get them? So you have to print out their, blood work, their CT scan, whatever they have done so far. So you have to do that and then give it to the patient. Physician can charge a reasonable fee, so you can charge the fee. It's not for free, okay? Provide the patients with access to their entire medical record. Exceptions include their instances where there's usually for the blood work, it's free. For the CT scan reports, it's for free. But when it comes to the doctor's notes, like, what we write down in the row notes that the patient came like this, he was having this, blah, blah, blah. In that cases, that is basically the charge. Okay. So for your understanding, I'm letting you know that what we charge. Provide the patients will access to their entire medical records and exception to the instances and their potential to serious harm to the patient. Provide the secure storage of information. So, when you are giving that paper, after that, you have to properly shred that paper. Don't throw it in the garbage. Anyone can get the access to that one. Ensure proper destruction of the information that is no longer necessary. So proper paper shredding or deleting the file or whatever. Then regarding taking the pictures and videos of the patients, finding or procedure. So, sometimes a patient come, okay, and he is recording or he is taking the thing. If you are not comfortable, you can always tell them, I don't want to do it. Okay. And in your case, you can ask the patient if they are comfortable in recording them or whatever it is. Okay. So if they are okay, then you can do it. In your case, you are okay, then they can do it. Okay. In addition to the patient consent and the privacy laws, transparency laws apply in the some provinces. CPSO is basically telling them this includes the implied consent, incapacity, and lock boxes. It is a physician responsibility to ensure the appropriate security provision with respect to electronic records and communication. With the advent of the Digital records, they have been increasing issues with our healthcare providers. They're not for the particular circle of care. So in that case, everything is in EMR with the name, surname, VIP, and all those big things. CPSO policy consent, in that one is basically valid consent before applying the medical and therapeutic and diagnostic procedure has been recognized as a elementary step in fulfilling the patient's obligation to the patient. So we talked about the confidentiality. Confidentiality is like keeping everything in short. It's a very single line thing. In short, keeping everything confidential unless asked by law. Second thing, like law includes the warrant, the court order, those things. Okay. And there are certain 5 things that you have to tell. The second thing is if there is any harm to some patient, then in that case, you have to block that. Again, in the circle of care, you cannot share if there is a lockbox or the patient strictly told you. Okay? Otherwise, everything should be kept confidential, regardless of anything. Like mom is asking, dad is asking, this is asking, whatever it is. Consent and capacity. Consent is allowing for something. It is either verbal consent, it's like we go for verbal consent as well. It's either a written consent, so we go for both of them. Consent is basically giving the medical intervention by the patient. So usually the principle of the respect of the patient autonomy must be balanced with the principle of the beneficence, such as the physician need not offer any intervention that does not serve some benefit based on their clinical judgment. Informed consent is a process, not transaction. So informed consent is like, in an emergency situation, it's basically implied consent. Informed refusal is equivalent in the principle and approach. Okay. So if a patient is deemed of the incapable of consenting, so he's not capable of it to a proposed medical intervention, then in the duty is basically the SDM to act on the patient's wishes. But again, you as a family physician working with that patient for 10 years and SDM tell you something and you feel like it is not the wish of the patient, you can always conflict with that one. You can always deny that and you can always challenge that. Okay, I hope this makes sense. There is a duty to discover if the proper whatever the patient must have wanted when capable. So this is what we are talking about. Central or determining the best interest in understanding and taking into account the patient values, beliefs, and preferences. Like he's Muslim, he does not want to go for something, so you shouldn't be going for that one. So most recent expressed wishes taking priority over the remote ones. So whatever they tell now will follow that one. The previous one is gone. Patient wishes may be expressed verbally or in the written. So if they're on the phone call and, like something like this, a patient comes to you, he is having appendix pain, okay, and he's incapable of making decision. And you know the SDM, you call the SDM cannot reach at the spot. So you asked on the phone for a verbal consent and they gave you verbal consent for appendectomy. So in that emergency situation, you will definitely go for appendectomy. Okay. So this is what I'm talking about verbally. Like um, like a person came and his sister was at home and she cannot come for some reason and they gave you a consent. In that case, we will listen to their verbal consent. If you can wait, if it's not an emergency situation, then we can wait. Patient wishes may be expressed verbally or in the written form. So this is verbally. Patient found incapable of making, like verbally is like something like this way. Like a patient came to the clinic. He told you, oh, if I ever, like, in the discussion, he said, if I ever get this disease, I will never, like, or in a fun way, oh, I don't want to get antibiotics. Or if in the say, he's like, oh, I never wanted to try antibiotics. In that cases, if he comes next time and he's not capable of making the decision and then substitute decision maker said, oh, I wanted to try him antibiotics. In that cases, you are aware that the person told you that he does not want to go for antibiotics. I hope this makes sense. So this is basically a verbal consent that the patient's wishes, like a 1 to 3 days ago, he was telling that he does not want to go for antibiotics. So we'll follow the patient wishes. Okay. So patient found incapable of making a specific decision. So he comes in the clinic. It's not an emergency. That's why I said we will not give antibiotics. Okay. If it's an emergency, then that's a different case scenario. Patient found incapable of making a specific decision should still be involved in the decision-making capacity process as much as possible. Although is incapable, he should